So, Dr. Rappaport. So, Adam is a general pediatrician with a master's degree in bioethics. In July 2011, Dr. Rappaport became the first medical director of the Pediatric Advanced Care Team, also known as PACT, the palliative care service at SickKids. PACT provides both inpatient and outpatient palliative care to children with serious illnesses and their families. In 2013, Dr. Rappaport was named to the inaugural medical director at Toronto's first pediatric residential hospice, known as Emily's House. He has more than 50 peer-reviewed publications and is a co-editor of the Oxford Textbook of Palliative Care for Children, which third edition was released in 2021. Without further ado, I pass it on to you, Adam. Thank you again for being here.
Thanks, Michael, and thanks to everybody for this invitation. I guess one thing that I left out of my bio is the fact that I sit on the Canadian Pediatric Society Bioethics Committee with Michael as well. So this is my talk today. You've seen the title. Let me make sure I can advance my slides. I have no relevant commercial relationships or other potential conflicts to disclose today. But I did want to disclose something else that maybe people have already honed in on. I am no subject matter expert here. In fact, that's why I chose to focus on this. This talk is not going to be about palliative care or end-of-life care. When Michael invited me to present a Dossiter Center seminar, he explained to me that this is an interdisciplinary forum, and it's all about the promotion of ethical engagement and critical reflection. So I'm going to step outside of my comfort zone today and use our time together to reflect on a case that I encountered more than 20 years ago, but had a profound impact on my practice then and still to this day. It's a case that demonstrated just how hard it can be sometimes to uphold what are basic and core ethical principles that I think we're all committed to, like honoring patient autonomy, when we're confronted with challenging clinical situations in the real world. I think the other thing that this particular case showed me is it exposed the power imbalance that can sometimes exist, or sometimes is highlighted between patients and physicians, especially when those patients are part of a vulnerable group. These are my objectives for today. I'll let you read them on your own. You notice from the title and in the first objective, my focus is on the province of Ontario. That's, of course, what I'm familiar with. However, in my limited research and from speaking with Michael, it is my understanding that while our laws, like in Ontario, we have the Healthcare Consent Act, while the title of our laws might be a little bit different, in general, our two provinces are governed by the same ethical codes and rules and regulations for how medical decision-making is made for our citizens. Okay, so on to the case. I want to introduce you to Mandy. Mandy is a 16-year-old previously healthy young woman. Mandy, at this time, was living with her boyfriend before I met her, as well as a few others of their same age, or roughly their same age, for the last 2 months. But she was actually brought to our Children's Hospital emergency department by her mother. Mandy had called her mom, asking her for assistance. When they presented to the emergency department, they told this story. Basically, for just over a week, Mandy had been experiencing left knee pain following what she thought was a bug bite. She went to a physician who took a look and prescribed an oral antibiotic called cloxacillin for a relatively minor skin infection or cellulitis. A few days later, Mandy went back to the same physician's office, and she was complaining of more pain. She definitely had increased swelling and was saying that it was really hard for her to bear weight on that leg. And so this time the physician added another antibiotic for broader coverage, something called Septra. Something that I do want to point out is that at this second visit, there was actually a lesion, sort of like a big pimple at the center of this swelling and redness. And the physician took a swab of that lesion, sent it to the lab, And Mandy and her mother brought the report to the emergency department. And what the report said is that the lesion was growing Staph aureus, a certain type of bacteria that, interestingly, was sensitive to both antibiotics that Mandy had been put on. And that suggests one of two things, or possibly both. One possibility is that this infection was a little too severe, maybe too deep. And even though she was on the right antibiotics to treat this infection, oral antibiotics just wasn't going to do the trick here. The infection was too significant. Or alternatively, perhaps Mandy wasn't being adherent to the treatment, missing some or all the doses. Again, it could be both as well. Let's proceed. In the emergency department, Mandy was seen by orthopedic surgery, who felt that an MRI was needed because they were concerned about a serious deep bone infection called osteomyelitis. The decision was also made by the medical team, by the emergency physicians, to recommend admission to pediatric medicine for IV antibiotics, and she would not likely need surgery down the road. And this is pretty typical. Orthopedics, if they're worried about osteomyelitis, they'll recommend medical admission to the pediatric medicine floor, treatment with IV antibiotics, orthopedic surgery will follow, and then take her to the OR if necessary. And so Mandy remained in our emergency department overnight. And I'd like to share with you some of the notes that I read in the charts when I became involved the next morning. First of all, it was noted that Mandy was increasingly combative, throwing objects at anybody that would walk into the room. She refused all examinations and treatments. She was verbally abusive to all staff members, including custodial staff who would come in yelling profanities at them, much to the chagrin of the parents of the small children in and around the hallway. Security had to be called in order for the IV to be inserted to give her the antibiotics. And in fact, security remained outside of Mandy's room for the entire night. And eventually a dose of Ativan, a benzodiazepine, was given for her agitation to try to calm her down. There were actually even concerns about Mandy's behavior and a question if something might be going on neurologically. Her mother had mentioned that she had been vomiting the past couple days and she was complaining of severe headaches. She was noted by the nursing notes in the emergency department to constantly be crying. She was also found at times to be disoriented and not making sense with some of the things that she was saying. And her mother also said that in communication with her over the phone, that she found her to be really irritable for the last 2 to 3 days. And so because of that, Mandy actually was sent for a CT scan of her head, which turned out to be normal. She also had a toxin screen, which came back positive for cannabis and ecstasy. Now, Mandy denied using these drugs in the last little while. She did admit to using them in the past. And keep in mind, she had been with us in our emergency department for probably the last 24 hours and under close supervision. And she was never seen taking either of these drugs here. And these can remain positive in the urine screen for a couple days. Okay, so this is where I come in. At the time, I was a senior pediatric resident, and I was asked by the emergency department to come and do the admission to bring her up to ped medicine for that IV antibiotic treatment. So I walk into Mandy's room and I say, "Hi, Mandy, I'm Dr. Rappaport. How are you feeling today?" And this is the response that I get from Mandy. "Okay, I'm going to try a different approach. Cut right to the chase. Mandy, can I examine your leg?" Well, she told me very clearly what I could go ahead and examine. And so I decided to try one more time, and I just asked her straight out, "Listen, Mandy, do you understand why you're here and why we need to admit you for IV antibiotics?" Well, Mandy said to me, "I don't care if I lose my leg. I don't care if I die. I just want to go home." All right. And then she told me where I can stick it. So I come out of Mandy's room, and the charge nurse working the emerge comes up to me and says, "Listen, Adam, we have to get this patient out of the emergency department right now. And I say to her, the trouble is she's not consenting to admission or my treatment. Well, the nurse, with that smile on her face, looks at me and says, listen, she's crazy. She's on drugs. Just Form 1 her. And so it's at this point that I want to change gears and talk a little bit about decision-making in the province of Ontario, which again, I think has a lot of similarities with Alberta. When a patient is confronted with medical decision-making, or when we're dealing with any kind of clinical situation where there's medical decision-making involved, we have to go down one of two paths, either the Mental Health Act in Ontario or the Healthcare Consent Act. For the purpose of this talk, I'm going to focus primarily on the Healthcare Consent Act, which is what I use in the medicine that I perform pretty much every day. But we'll take a quick detour on the Mental Health Act because the nurse had mentioned that we should just Form 1 her. The Mental Health Act is something that basically provides criteria for involuntary admission against a patient's wishes or treatment, but it has to be in a psychiatric facility. I should mention my institution, Sick Kids, is not considered a psychiatric facility. What about this Form 1? And I'm pretty sure I looked it up online. I'm pretty sure you also have a Form 1 with very similar criteria. Basically, a Form 1 can be completed by any physician in Ontario, and it allows for an individual like Mandy to be detained in a psychiatric facility for assessment only for up to 72 hours. If we want to take it further and maybe subject the patient to treatments against their wishes, there are other forms that have to be completed following the Form 1. One more caveat to completing a Form 1, there must be a suspected or known mental health disorder. So what about Mandy? Is this nurse right? Can I complete a Form 1? Well, there is no known or suspected mental health condition in this case that I got from speaking to her mother. It's true, a Form 1 can be given for substance use disorder, which could be considered a type of mental health disorder. But the most important thing is that, at least in my opinion, is that any organic condition, like a bone infection or osteomyelitis, must be treated and the patient must be physically stable before they can be transferred to a psychiatric facility for further assessment. And so in terms of what should I do in this situation with Mandy, as far as Form 1 goes, I have to say that there is disagreement about the appropriateness in this situation. I spoke to a lot of people at that time, and we'll come back to some other investigations I did regarding what should I have done in this situation. And I think it's fair to say that different people, feel differently about the Form 1. But the main point is the second bullet point here, which is regardless, a Form 1 would not address decision-making around the osteomyelitis. And that's the main focus that I want to draw your attention on today. And so I decided Form 1, despite what this charge nurse has suggested, was really not going to help me in this situation. So the question that I'm faced with here is, should I respect Mandy's autonomy and let her go home? The concern that I had as the treating physician is that if I do so, she's likely going to get worse, and that will increase the need for surgery. She might become septic, which means that the infection could spread to her bloodstream, and that could make her really sick, could possibly even lead to death. Even an amputation was possible if I let this fester and let her go home. She was quite unwell by the time she came in to see us and emerge. Of course, the other thing I want to know is, do I have any other options? And so, as I mentioned, our main focus today is to look at Ontario's Healthcare Consent Act, which basically the purpose is to provide rules with respect to consent to treatment in all settings, to facilitate treatment and admissions for persons lacking capacity to make such decisions, to enhance patient autonomy and communication, and to ensure a significant role for supportive family members when a patient does lack capacity. So this is sort of the path that we're going to be going down for Mandy. One of the really important things in our Healthcare Consent Act is it says there is to be no treatment of a patient without their expressed consent, except in an emergency setting. And so that got me thinking, maybe I don't need Mandy's consent to admit her and administer these IV antibiotics. The question that we need to answer is this indeed an emergency? And again, there's guidance within the Healthcare Consent Act as to what an emergency is. Here's what it says. There is an emergency if the person for whom the treatment is proposed is apparently experiencing severe suffering or is at risk, if the treatment is not administered promptly, of sustaining serious bodily harm. Now, in practice, what we know from looking at other legal decisions about this matter, both in Ontario and across Canada, is that there is a real high bar for what is considered an emergency. In general, for the most part, the patient has to have a limb or life-threatening condition, and there really can't be time to properly discuss this and review with the patient. Most would say that Mandy's situation is considered urgent. It's clear we got to deal with this or she's going to get into more serious trouble. But I think it would be hard to say at this point that this is a true life or limb threatening emergency. And so it comes back to this situation about no treatment without patient consent. It's up to me, the treating physician, to determine if the patient is capable of consenting. If my findings are that indeed Mandy is capable, then I have an obligation to inform the patient of the treatment options. The patient then provides consent to a certain treatment or refuses the various treatments. And ultimately, the patient's capable decision has to be respected. If, of course, my determination is that the patient, in this case, Mandy, is incapable, then our Healthcare Consent Act says a capable substitute decision maker must be identified. And I'm not going to go into the pecking order here, but to say that that's all laid out as well in our Healthcare Consent Act. And in this situation, it would be indeed her mother. Let's talk a little bit more about how we are to determine capacity in Ontario. And again, I happen to know that it's basically the same throughout Alberta and indeed most of Canada. Here's what our Healthcare Consent Act says. A person is capable with respect to a treatment or admission if the person is able to understand the information that is relevant to making a decision and is able to appreciate the reasonably foreseeable consequences of a decision or a lack of decision. Now you'll notice I underline two words here, understand and appreciate. These are definitely the two words that are that were hammered into me, at least, when I was in med school and throughout my residency. These are sort of the key factors that a patient has to demonstrate in order to have or to be determined to have capacity to make a medical decision in a specific situation. Understand and appreciate. And our Healthcare Consent Act says that there is always a presumption of capacity. It's up to me to investigate, to speak with the patient, to talk with him or her, and determine if indeed they do understand and appreciate. And as a result of that, because there is a presumption of capacity, in Ontario, we say that there is no age of consent. As long as they understand and appreciate, regardless of their age, I have to assume that they're capable and proceed. And again, it's my understanding that the same is true in the province of Alberta, and indeed throughout most of Canada, with the exception of Quebec. I will also mention that it is well known that the courts tend to put autonomy and capacity, particularly when a patient has capacity, above all else. And I've listed a number of landmark cases here where this is so. So the question then that we're faced with here is the difference between a patient like Mandy being incapable versus capable, but making what I might consider, and maybe you would agree, a bad decision. And what's the difference here, and how do we decide what's happening and which one of those two things is indeed occurring? And to figure that out, I want to sort of take you down a little sidebar and share with you a really interesting court from the case from the Supreme Court of Canada in 2003. This is a case called Starson versus Swayze, and I'll try to summarize the key details here for you. The defendant, Professor Starson, is somebody that is known to be diagnosed with bipolar disorder. Professor Starson has frequent admissions to psychiatric facilities across the course of his life. And relevant to this hearing, he had been ordered by the courts to be detained in hospital for 12 months for psychiatric assessment and treatment. During this 12-month period, he was refusing all the medications that were being recommended by his physician. And eventually, he was deemed incapable to consent by this physician caring for him at the medical facility. Well, Professor Starson and his lawyer took this to the courts, and indeed, his incapacity finding was upheld by an independent review board that saw him. But Starson and his lawyer were not done, and they took it all the way up to the Supreme Court of Canada. And it might surprise you to find out that the Supreme Court of Canada ended up upholding Starson's right to refuse treatment. And in doing so, they focused on the Healthcare Consent Act and this paragraph that I'd shared with you before. Now, remember, when we talked about this paragraph just a couple slides ago, I had told you that the emphasis that I had always learned to sort of focus on were the terms understand and appreciate. But what the judges wanted us to focus on in their decision was the single word here, able. In their ruling, the judges said that the act requires a patient to have the ability to appreciate the consequences of a decision. It does not require actual appreciation of these consequences. Furthermore, in their decision, they said the right knowingly to be foolish is not unimportant. The right to voluntarily assume risks is to be respected. Okay, so let's try to add this all up here and make sense of it. The first thing that I need to figure out as the treating physician for Mandy is the patient able to understand and appreciate the situation, the various treatment options, and perhaps my recommendation? Remember, in the case of Starson, he was determined not to be psychotic at the time of the decision. So even though there were times that he was clearly in a psychotic episode and he had this underlying diagnosis of bipolar disorder, one of the reasons why the Supreme Court upheld his right and the fact that they said he was capable is that it was clear that at certain times when he refused the treatments, he was not in the middle of a psychotic break. For Mandy, it's true that she was found to have certain substances in her urine, but everybody involved in Mandy's case in the emergency department, including a variety of consultants, determined that she was not actively intoxicated at the time of this decision. And I want to remind you that her age of 16 was completely irrelevant. So the next question is, has the patient been adequately informed? Both Professor Starson and my patient Mandy received relevant information. But patients have the right to choose not to be informed. They don't have to listen to it all. They can ignore what we have to say. They can do what they want with it, to be honest with you. We just have to make every attempt and overcome whatever obstacles that might be in our way if possible, like language barriers, etc., to do our best to inform the patient. But if these two things have happened, then ultimately their decision should be respected. Okay. So at this point, I want to pause and I'd love to get your input on this. I don't know if people have seen this before, this thing's Slido, but if you take your phones out and you scan that QR code, you should be taken to a slide that basically has these two options on it. And I would love for you to tell me, what would you do in this situation if you were me, the treating physician? Would you declare Mandy incapable of consenting to the treatment and try to, go around her? Or would you let her go home without the recommended treatment, basically in accordance with her wishes? So again, if you can scan the QR code or go to slido.com and enter that number, you have the opportunity to enter your vote. I see that we have 40 people online. So far, 3 of you have made a vote. So we'll give it a couple more seconds to see if we can get that number up a little higher. I'll take a quick sip of water. You seem to be stuck at 8. Can we get above 10? There we go. We're at 10. Okay. I think for time's sake, we will continue, but we're at 13. Let's see what we found. Okay. So the majority of people said that they would let her go home without the recommended treatment in accordance with her wishes, about 60%. 40% said that they would declare Mandy incapable of consenting to the treatment. Now, I understand I've got the mic. I created the slide. It's quite possible that some of you are thinking about other things, but I appreciate you sharing your opinions here. In a second, I'm going to tell you what I did, but before I do that, I'm going to sort of fast forward. Once this case was finished, and as I said, it had a profound impact on me, I did want to try to learn more about this. And so weeks after this was done, I actually reached out to the CMPA, which is the Canadian Medical Protective Association that guides physicians through challenging circumstances to make sure that we're doing things appropriately and legally so that they have our back if we were to get sued or get into trouble. And it just so happens that the consultant at the CMPA that I spoke to about this case was a former adult emergency department physician. And so he might actually see things like this in his practice. And so I told him about Mandy and the situation. And the first thing I said is, would you have actually given a Form 1? And he said, yeah, we would have done it in RED for sure. I thought that was pretty interesting. The next question I had for him is, could I have treated Mandy without even getting consent because it's an emergency situation? He said, yes. There's an unknown etiology or cause to her unusual behaviors. Could she have an encephalitis, which is a type of brain infection? Could she have a sepsis? I mentioned that earlier, where maybe the infection had spread to her blood and caused her to not be in the right state, and this could be more serious. I then asked, what about deeming her incapable? Basically saying you don't have the capacity to make this decision, and turning to a substitute decision maker who will hopefully agree to my recommendations of IV antibiotics and admission. And he said to me, yes, it really all depends on how you approach your capacity. So again, this physician had no problems at all doing all 3 of these things. I also reached out to something called the Consent and Capacity Board. This is a board in Ontario that all patients have access to. That basically consists of a healthcare provider, healthcare professional, a lawyer, and a lay person from the public. And this 3-member panel will listen to difficult situations like this, where it's unclear whether or not a patient is capable of making their own medical decisions. Of course, there's lots of steps you have to go through before you go to the Consent and Capacity Board, but in exceptional circumstances, we have the ability to go there. And so I reached out to the CCB and I asked the lawyer there, what do they think about this case? Well, regarding Form 1, this individual also said, yes, you just need a possibility of a mental disorder. Again, I found that really surprising. As I mentioned, I don't think that really would have got us to where we need to go with Mandy. We still need to deal with her osteomyelitis, which is a whole other issue. But I was just so surprised that this lawyer and the individual from the CMPA so readily said, yes, I could, admit this patient to a psychiatric facility against her wishes, given the facts of this situation. What about an emergency decision? Well, this lawyer said, that's not my call. I'm a lawyer, not a medical practitioner. Fair enough. And then I asked him, what about deeming Mandy incapable? And here's what he said. No, the burden of proof is on the physician to show that the patient is incapable. Remember, we have to presume that all patients are capable. You, meaning me, have not been able to show that the patient does not have the cognitive ability to understand the consequences of her decision. All right, so let's get back to Mandy. Here is what I did. First of all, and this is a lesson to anybody that's sort of in the earlier stages of their medical career, I remember that I'm never alone. There's always room for help, and there's nothing quite like having colleagues to lean on when you're in a difficult situation like this. And so we got adolescent medicine involved, bioethics, psychiatry, and we all put our heads together on this one. Ultimately, it was agreed upon that Mandy was not capable to make this decision about admission to hospital for IV antibiotics. And our general reasoning for this was we felt that she was overwhelmed. And I'm not going to get into detail about this. I've provided a really interesting reference at the bottom of this slide if you want to read more about this. But it has been described that some patients could be so overwhelmed by their medical situation that they're no longer in a state where they are capable and able to make sound medical decisions for themselves. And I would basically say that that was the reason that we felt Mandy was incapable and that we overrode her wishes and eventually made her mother her substitute decision maker, which is in accordance with the pecking order in our Healthcare Consent Act. Her mother readily agreed to the admission and giving IV antibiotics, and she also agreed that the need for surgery would be reassessed after about 24 hours to see if that was required. You know, one thing I will mention is that her mother couldn't believe the time and the lengths that we went to trying to figure out if Mandy could make this decision. She thought, you know, it was ridiculous that we were listening to her in this state that she was in. She couldn't believe that we weren't just, you know, doing what needed to be done, I think was her exact words. And so with her mother's permission, the IV was restarted. Antibiotics were indeed given, but this had to be done using both physical and chemical restraints. So Mandy was literally, I wouldn't say chained to the bed, but tied to the bed in order to do these things. It was awful, to be honest with you. Mandy received 24 hours of IV antibiotic therapy on the wards that I was looking after her on. She required security outside of her room at all times. She was quite agitated. Orthopedics did follow her during this time, and eventually they got to a place after about 24 hours of IV antibiotics that they felt that she did need to go to the OR. They felt that the right thing to do was to go in there, take a look, clean up and sort of wash out the area, maybe try to get another sample to help this infection clear up. And so they had notified Mandy, her mother, and our team that they were going to be taking her to the OR the next morning. I got to tell you again, I felt really, really bad about how this had all played out. Mandy hated me. If I came in the room, she was just crying at all times, yelling profanities at me. And, you know, it was a really difficult moment, I have to say, as her physician. But I will also say that I did feel confident that she was getting the right care. Until that is, a member of the larger team, someone from bioethics came up to me and was reviewing everything, and they asked me this question. You did tell Mandy that she has the right to appeal your finding of incapacity. Let me explain. Any patient that is found to be incapable by a physician also has the right to contest that finding. That again is something that goes to a rights advisor and sometimes to that consent and capacity board. And here's the catch. If that patient does wish to appeal a physician's finding of incapacity, then we are not allowed to start any form of treatment. Whoops, keep in mind that I had already admitted her against her wishes. I had pinned her down, put in an IV, was giving her IV antibiotics, made her NPO to prepare for surgery the next morning. This was not a good situation. So after learning of this, I did go back into her room and I said, Mandy, there's something I need to tell you. I informed her of her right to appeal the incapacity. And at this point, we're about 2 hours before she is scheduled to go to the operating room. Well, Mandy said to me, I am not incapable. I absolutely want to appeal. Not surprising. I explained to her that as a result, the surgery needs to be put on hold until after this review is done, unless she just consented to going forward with the surgery. She said to me, I don't agree to anything that you say, but she did acknowledge she wanted to have the surgery so that she could get out of this place and get home. Well, in light of the fact that she was refusing to give consent, I think primarily because she just didn't want to agree to anything that I or anybody else was suggesting, I said to her, really, the only way to go forward with the surgery at this point was to waive your right to appeal, because again, we can't put her through any treatment, including going to the OR, unless she consented or waived her right to appeal her finding of incapacity. And she said to me, I am not effing incapable. Of course I want to appeal. We went around and around this way for a few minutes. And as we kept going, she cried and cried more. And I could literally see how much I was beating her down through this ridiculous cycle. Eventually, Mandy waived her right to appeal because she just wanted to get out of hospital and get this over and done with. I think many people would say that Mandy's decision was made coercively. And so with that, we come to the end of the case, and I'm going to open it up to discussion in a second, but a few key takeaways that I wanted to share with you. First of all, Ontario's healthcare system, and indeed I think the healthcare system across all of Canada, prioritizes autonomy for all patients, including adolescents. There is generally a presumption of capacity. And in most instances, every day, it is both legal and ethical to respect a capable patient's wishes, even if doing so may cause that patient some harm. The other thing I want to point out, or I hope I pointed out, is that clinicians have a great deal of power and influence. And along that line, I would say that age does matter. Even though we always say there is no age of consent in Ontario and Alberta and in the other provinces, I got to tell you, I do believe that it was because Mandy was a 16-year-old child who I thought was terrified of what was going on and probably in a lot of pain. I think that that is why we as a larger group, certainly me as an individual, we overrode her capacity and went down the path that we went down. I think age does matter, especially when the stakes are high. I'm not sure what would have happened in an adult emergency department if Mandy was 46 or 56, but I get the sense that there are more physicians that would have said, okay, come back when you're ready. And the last thing is sometimes following the rules or the ethical guidelines can leave us feeling like we've still done something wrong. I got to tell you, as much as this pains me to relive this case and to think it through, and as I mentioned, I gave a lot of thought to this case in real time and going back to this now to prepare these slides. I'm not sure that the real substance of what I've shared, I'm not sure that I would have done a lot of things all that differently. Specifically, I think I still would have chosen to override Mandy's capacity, even though that lawyer from the Consent to Capacity Board said I didn't meet the threshold here. I just couldn't take the thought of Mandy coming in really, really sick and potentially getting into a lot of trouble. And, you know, the idea of sort of following the letter of the law here, and saying, listen, she has capacity, which is what 60% of you said, I think that would have really tormented me as a treating physician here. Again, I hope you're picking up on the fact that I was tormented either way. I felt just awful, and I still feel awful to this day about how Mandy was treated in this situation. I guess sometimes you're damned if you do, damned if you don't. And so with that, I'd like to thank you. I hope I've left enough time for your comments, questions. I guess Michael's here. I'll stop sharing my slides and hand the mic over to you.